Well, good morning, everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. A couple key announcements for today, and then we'll get started with introductions. Next week will be our final Grand Rounds of the spring season. Please be sure to join us for the Andy and Bev Hansel Lecture in Ethics. It will be Seeing a Future at Risk, Personhood, Moral Triage, and Lifeboat Ethics, given by Kevin Dirksen. And again, that will be the final grand rounds of our spring season. And so go ahead and enjoy some found time after next week over the summer and rejoin us the Tuesday immediately following Labor Day in the fall. A few logistics. Most of you know that Grand Rounds is a joint effort between Providence Portland and Providence St. Vincent Medical Centers. We're here live in Southern Auditorium at St. Vincent's, where we typically are at 8 a.m. on Tuesdays. Sometimes the talk is also live at Providence Portland, typically at noon, also on Tuesdays. Welcome to those of you who are joining us on Teams Live. And as you know, you can get CME credit by being here in the room, by being live virtual, or by watching a recording of the event. And if you look at the email each week with the Grand Rounds invitation, it will tell you exactly where and when we meet, and we'll also have the link to watch the video. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions, those of you joining us online, and I'll mostly hold those until the end as time permits. And now I am delighted to introduce today's speaker, Dr. Kieran Beyer. She's the Clinical Medical Director at Providence Gateway Immediate Care since January of this year. Dr. Beyer completed her medical school at the George Washington University School of Medicine and then went on to do emergency medicine residency at OHSU. She worked for over 20 years at Legacy Mount Hood Medical Center as an ER physician, along with shifts that she would pick up at Providence Hood River. And now Dr. Beyer lives in Hood River with her family, where they enjoy wind and water sports and everything outdoors. Dr. Beyer, thanks so much for joining us today.
Thanks so much for having me. I'm really excited to be here. And today we're going to talk about women and acute coronary syndrome. And when I was preparing this talk and doing research for it, it really scared me because being in the ER, we get people coming in with chest pain all the time. And you have a sense of what a chest pain person looks like, what an MI person looks like. And so I found gender bias in myself. And moving forward, even in the urgent care, we get MI patients come in periodically. I just want to make sure that I'm encompassing the whole person and not just that vision that I have in my head. So I have no disclosures. And for our time together, we're going to talk about risk factors for women, risk factors for ischemic heart disease, and the differences between men and women. We're going to go over a little pathophysiology, and I'm going to try and run through that quickly so we don't lose time. And we're going to go over symptomatology, and because there are differences in men and women. And then we're going to talk about disparities in diagnosis, treatment, and outcomes because they're there. And then we're going to talk about what we can do moving forward to improve care for our patients. So I'd like to start with a case. And this is a 58-year-old woman. She presented to clinic complaining of maybe having something stuck in her esophagus. She was eating spicy chicken. And as she was about to swallow, she actually swallowed some and then started coughing really, really hard. She was able to eventually swallow all of the food, but she had really bad pain in her esophagus and some burning. So she decided to come into the clinic to get evaluated, and she has no history of GERD or reflux, and this has been ongoing for 3 days. So in terms of the physical exam documented in the note, she was sitting on the table, she was crying, saying she was in pain, and she was in emotional distress. You can see she was hypertensive. The rest of the exam is primarily normal, including an abdominal exam. But on the psychiatric exam, they noted that she was anxious. She had a depressed affect, and she was emotionally labile. So this clinician felt like most likely she had esophageal spasm, maybe some irritation in the esophagus. They didn't think she had a foreign body there. They referred her to GI. They made some dietary do's and don'ts. And she continued to have pain during the visit, and they'd given her a GI cocktail, but it didn't really affect the pain. And it was recommended that she start a PPI and try Maalox. So later that day, and this is usually a harbinger of bad things to come. It's kind of like in the ER when your colleague, when you first go on shift and your colleague is like, hey, remember that patient you saw the other day? Really gets our heart beating. And so she came to the emergency department later in the day, about 5 hours after her presentation to clinic. And she was complaining of chest pain, and she also had some shortness of breath. And that was the main reason why she came in, because pain was getting worse, and now she was feeling a little short of breath. And she told the triage nurse and the ED physician that pain started 3 days prior, and it actually went away the day before and then came back today. So after a visit to the primary clinic, again, some shortness of breath and worsening of the pain. So that's why she presented to the ER. She was still hypertensive, even more so now. And this time she was diaphoretic and looked really uncomfortable. So the differential diagnosis by the ED physician was first acute coronary syndrome. They thought about GERD. They agreed with the clinic. They didn't think she had a foreign body in her esophagus. They also considered intra-abdominal pathology, aortic pathology, possible pneumothorax, but they didn't think she had a PE or pneumonia. And so an EKG was quickly obtained, and this is what it showed. So as you can see, we've got some ST segment elevation laterally. We've got some ST segment depression in V2 and V3. So this was called as a STEMI. She went to the angio suite, and she was found to have multivessel coronary artery disease. So she had high grade mid-obtuse marginal branch stenosis, and they felt that was the likely lesion that was causing her STEMI, but she had other critical lesions in different arteries as well. So she had a PCI of that obtuse marginal artery. And then on hospital day 2, she got an echocardiogram and was found to have an left EF of only 45 to 50%. And she had hypokinesis of the basal infralateral wall. So the next day, she went back to the angiography and had PCI to the mid-LAD and distal circumflex as well. After a 6-day hospital course, she was discharged. So take-home point. Most of you know this, and maybe some of you don't or don't take this into consideration, just in the forefront of your mind with your patients. But heart disease is a leading cause of death in women. You know, we always think of it as a male disease. Again, that visualized patient that I have, barrel chested, someone in his mid-60s, diaphoretic, clutching his chest. I rarely think of a woman. If you said, I have a patient with an MI, a female patient doesn't cross my mind first. And I've been an ER doc for 20 years, and we've been trained to think everyone has an MI. So this is taken from the CDC. It's just a graph that shows that women have the most number of deaths due to heart disease, surpassing cancer. So the big picture, it's not a really happy picture for women in ACS. First of all, they're less likely to seek timely treatment, and we'll go over that. They're less likely to get bystander CPR. They're less likely to get aspirin or nitro from EMS, and also less likely to go via lights and sirens. They're less likely to get timely door to EKG times. They're less likely to have an early diagnosis of ACS, like the patient in the case, and they're less likely to get guideline-directed therapies. But they are more likely than men to die within 1 year of having an ischemic event. So let's talk about cardiac risk factors in women. We've got normal cardiac risk factors that you think of when someone presents with an MI. You've got hypertension, diabetes, smoking, hyperlipidemia. The key thing here, though, is that hypertension and diabetes have a greater impact on women and the development of coronary artery disease than it does in men. And the hyperlipidemia does get worse after menopause. And smoking is a risk factor for women presenting with STEMI. Women have a lot of unique risk factors, and these are the ones we don't typically think of. So that could be when menarche starts, early menarche especially, early menopause, endometriosis, and that's something I would never have considered. And then PMOS, formerly the polycystic ovarian syndrome. Other unique risk factors are basically almost any complication in pregnancy. And I can kind of understand preeclampsia, eclampsia, gestational diabetes, hypertension in pregnancy, but we're also looking at preterm birth, hemorrhage, and placental abruption. So all of those have increased risk factors for the development of coronary artery disease. And then the elephant in the room, menopause. So there's a huge spike in risk factors for MI once a woman enters menopause, and it's due to the loss of estrogen. So estrogen has a lot of good properties. It inhibits smooth muscle proliferation. It regulates prostaglandin. It has protective properties for the endothelium, has vasodilatory properties, and also some antioxidant properties. There's also other unique risk factors that we need to take into consideration. Depression, which is 2 times more common in women than men, is a strong predictor of early MI. And there's also a really robust association with MI and cardiac death in young and middle-aged women with depression. There's also stress, increased stress, whether home or work, major adverse life events. High stress at baseline has actually been associated with worse recovery 1 month after MI. So I'm going to try and run through this pretty quickly. So just to go over some pathophysiology, most of which, the internal medicine physicians are going to know, but just to lay the foundation and the baseline. So plaque rupture, the traditional thing that we think causes MI, is still the most common cause of MI in women. But interestingly, ANOCA-MINOCA, so myocardial infarction and non-obstructive coronary arteries, is 2 to 3 times more common in women than men. And with the advent of statins and better preventative care, it's actually approaching almost half of all ACS cases in women under 65. So there's an umbrella under the MINOCA-ANOCA categories. And so that includes plaque erosion, spontaneous coronary artery dissection, coronary artery vasospasm, and then the microvascular dysfunction. And I'm not going to talk about calcium nodules or myocardial bridging because those are not necessarily more common in women. So we're going to focus on the top 4. So plaque rupture versus erosion. On the left, we have a drawing of the typical plaque rupture with a large lipid core, rupture, thrombus formation. And then on the right is erosion. The dotted line represents the endothelial layer. And for various reasons, you can get erosion of that layer and you get thrombus formation due to aggregation of platelets. So this is really common, and not really common, but again, more common in women under 65. Smokers are more at risk for this. It presents typically as an NSTEMI, and it occurs in areas of high shear stress. And it's diagnosed via optical coherence tomography and intravascular ultrasound. So treatment is kind of standard treatment, statins, ACE, ARBs, lifestyle changes, and then it is typically treated with a less invasive management. So dual antiplatelet therapy followed by for 12 months. And then if there is a larger thrombus, that white thrombus, you can do thrombectomy and dual antiplatelet therapy. And they typically want to avoid stent placement just due to the risk for arterial damage and also the risk for restenosis. And for most cases, conservative management is appropriate. And again, PCI for critical obstruction, but otherwise conservative treatment. And then I want to move on to coronary artery dissection. And this is a disease of women. So 90% of cases are in premenopausal women. And they make up, some studies say, almost a quarter of ACS cases in very young women that are premenopause. It's more frequent in women who've had preeclampsia or multiple children, and 15% of all cases occur in pregnancy. It's still a rare disease, but just be wary if you have a pregnant patient who's complaining of chest pain. We do need to take that seriously. And it's most often in the third trimester or postpartum period. Typically affects the left anterior descending artery. And the key here is that there's long segments involved. It's not just a little focal stenosis that you can go in and fix with PCI. There's a long segment involved in that dissection. So risk factors, again, pregnancy is a risk factor. Fibromuscular dysplasia is one of those really strong risk factors. So if you have a patient with fibromuscular dysplasia coming in with chest pain, premenopausal, you really have to think of dissection. Other things are things like inflammatory diseases, connective tissue disorders. There is a genetic predisposition. And then emotional stress. So again, going back to the increased risk of MI with high stress and those psychosocial factors. Intense physical activity and also exposure to extreme cold has been thought to help contribute to this. And the only classic risk factor that women can have with this is hypertension. I mean, they may still have coronary artery disease, but it's not necessarily a predictor of SCAD. So just quick look at mechanisms. The inside out is this tear in the intima with the formation of a false lumen. And then the outside in is a tear in a small arteriole within the wall of the vessel. And that creates pressure due to blood accumulating outside of the vessel. So treatment. So it's conservative treatment. Recommended dual antiplatelet therapy followed by aspirin lifelong. Use of anticoagulants is still under debate. And typically, statins are not recommended except in those individuals with hyperlipidemia. And beta blockers help reduce recurrence. And it's common to get recurrence with SCAD. Typically, it is in a different location than the original dissection. And they still recommend basic cardioprotective treatments like nitrates, calcium channel blockers, ACE ARBs. And these are recommended by the AHA, but there's really no studies saying that this is the best thing to use. And PCI really is only in a very few cases. And that's because of the risk of bleeding and the risk of damage to the arterial wall. And so you've got somebody in cardiogenic shock, fatal arrhythmias, and left main involvement. And in case that fails, you get the damage or some complication, patients will undergo CABG. So this is just a quick summary of how it's diagnosed and what to look out for. So angiography is used to diagnose it. Also IVUS, optical coherence tomography, and CTCA. So I'd like to go on and talk about vasospasm. And people kind of hear this and associate it with women, typically women who are under stress or having an emotional experience. But it's multifactorial in terms of the causes. So it could be ANS dysfunction, inflammatory states, oxidative stress, and again, going back to that endothelial cell dysfunction, hypercontractility of those smooth muscles. There is a genetic component to it. And again, psychological stress can be a contributor to vasospasm. And stimulant drug use and smoking is also a risk factor. So treatment for vasospasm, nitroglycerins for acute episodes, then treatment with calcium channel blockers, long-acting nitrates, and statins, kind of typical medications. And they also recommend stress management. And the key thing here is to avoid beta blockers because they can potentially make the spasm worse. And I had a little video here. So this is typically diagnosed during angio with the introduction of acetylcholine into the vessel, and this causes vasospasm in women who are susceptible for this. So let's see if it plays. It may not play. Oh, it's not playing. That's okay. You see you see the vessel kind of disappear with introduction of acetylcholine. So treatment, as we talked about just a minute ago. And then we're going to move on to microvascular dysfunction. So this has to do with the microvessels that are not visible via angiography. And it basically has to do with limited coronary flow reserve and endothelial dysfunction in these small, tiny resistance vessels. So this can be debilitating for women. They get persistent chest pain, it's recurrent. They've had multiple evaluations. They don't have obstructive arteries, and it can lead to ischemia. So with these multiple evaluations, you come into the ED, you get double troponins, EKG, everything can give a false reassurance. And there's actually a pretty high risk for major adverse cardiac events following an ischemic event with microvascular dysfunction. So basically, it's just a problem with this microcirculation, and it can be caused by, again, some of the things we talked about in the regular coronary arteries, including endothelial problems, inflammatory states, aging is a risk factor, dysfunction of the smooth muscle, and that vasospastic occurrence, and just autonomic nervous system dysfunction, and then just in terms of like vasoconstriction and vasodilatation, you get an imbalance of both of those. As far as treatment, it's the classic things that you would think of for almost like a typical person with coronary artery disease: aspirin, statins, plus or minus beta blockers, depending on which category that microvascular dysfunction falls under. And then PRN, nitroglycerin, for these episodes that, again, are frequent and often debilitating. Lifestyle modification, including stress modification, dietary modifications, increasing exercise, and smoking counseling. I just want to touch base really quickly on clinical research, because this drives what's happening with women in ACS. And for the longest time, women have been underrepresented in clinical trials. So in terms of cardiovascular disease, stroke, CAD, peripheral artery disease, women are underrepresented anyway, but looking specifically at coronary artery disease, less than a third of participants are women. So a lot of our treatments have been made looking at men and what works best in men. And so this, in these studies that are done, the sex-specific data is underreported. And this underrepresentation results in uncertainty. You know, do we really know these treatments are safe and effective in women? And so I want to go over two studies that laid the foundation for future research. And one was the WISE study, started in 1996, spans decades. And it gave us a really good representation of some of the causes of ischemic heart disease in women, and it sought to improve both diagnosis and long-term outcomes. So it helped us get knowledge of microvascular dysfunction, and it also found differences between men and women that caused delay in diagnosis. And the next study, I just wanted to highlight that people go back and analyze the data and come up with new studies, is the Virgo study. And this looks primarily in young women aged 18 to 55. And it looks at sex-specific differences in both symptoms, presentation, recovery, outcomes. And they had a ratio of 2-to-1 female to men. And they looked at different classifications of acute MI, and they looked at specifically at outcomes, including morbidity, like functional outcomes, and psychosocial status, depression, anxiety after MI, both of which are high. And it also looked at 1 and 12-month mortality. So now I want to go into this patient who comes before you. She walks into clinic, maybe she's 48, 50, and she's coming in with the following symptoms. She may have chest pain, but about 25% of women, especially younger women, may not present with chest pain at all. And women are more likely to present with 3 or more symptoms compared to men. And so we want to stop using atypical to describe angina symptoms in women because it may be different than men, but that doesn't mean it's atypical. These are typical presentations for women. So people are stopping to use that term. So again, chest pain, they can have abdominal pain, just like men, epigastric pain, esophageal pain, as our patient had. They can also have shortness of breath and then some vague symptoms. They can have anxiety. Again, our patient was emotionally labile, very anxious. They can have dizziness, fatigue. So some of these things don't always come to your mind when you're thinking of acute coronary syndrome. As far as presentation delays, women tend to present much farther out than men in terms of time to first medical provider interaction from symptom onset. So the average time to presentation is like 2 to 5 hours, both men and women. But looking in the Virgo study, they found that women were more likely to present greater than 6 hours after symptom onset. And again, our patient in the study had chest pain. It sounded like from the ER, it kind of came and went, but she waited 3 days to get evaluated. So the reason for these delays are people being unaware of their risk factors for heart disease. About 50% of the population does not consider heart disease as the leading cause of death in women. They don't know their risk factors. And about 21% of female patients who've sustained an MI said they did not talk with their provider about their risk. And women are also more likely to attribute a symptom to something else, like, oh, I just ate some chicken and it's just not settling well in my stomach. I'm feeling a little bit tired. I've got a little shortness of breath. But they may or may not discuss chest pain. And then barriers to self-care. Women tend to have more duties at home, even if they're full-time employed. And so things like, well, I have nobody to watch the kids, or I've got to pick up my kid from school and nobody's there to do that for me. And that will delay care. And this has been shown in studies. So there is a delay in diagnosis. And again, part of it is gender bias. And we really need to look at that in ourselves and our colleagues. Even in 2026, that gender bias is there. There's underestimation of risks by clinicians and underestimation, again, in risk by the patients themselves. And there was one study that showed that PCPs ranked heart disease in terms of priority below weight issues and below breast cancer concerns. So it's not necessarily in the forefront of people's minds, especially in that younger population. There was a trial called the high stakes trial that looked at sex-specific cutoffs for troponin, because all of these troponin cutoffs have been designed by trials in men. And by lowering the cutoff for troponin in women, when they're evaluated, they actually picked up 5 times more heart injury than looking at men. The only caveat to this is that outcomes were not changed. So there's still debate about whether or not this should be instituted. But delays, differences in symptoms. There are delays in door to EKG time, and this is well documented, anywhere from 3 to 9 minutes. And you may say, well, that's not that much. But when you've got a door to cath time of 90 minutes, if you have a cath lab in your hospital, that 9 minutes can make a big difference. And also, the biggest predictors of missed MI are young age and the absence of chest pain. So we just need to broaden our differential, include some of these other symptoms, and not to be falsely reassured by women who are less than 50. So what happens in terms of treatment? So women are less likely, we mentioned this at the beginning, less likely to get aspirin and nitroglycerin from EMS and less likely to go via lights and sirens. Again, it's that gender bias. It's that thought that, well, this younger woman is at less risk just by being a woman and being under 50. She's anxious. She may not complain of chest pain. We see that in our EMS colleagues. There's lower rates for PCI, and part of this is due to the fact that women in MI just in general tend to present later than men in terms of age. And so there may be more risk factors for undergoing PCI, smaller vessels, and more risk factor for bleeding. But there is a difference. Interestingly, and we're going to delve a little deeper into this, there's less referral to cardiac rehab. And among patients who do get referred, there's less participation and there's greater risk for them stopping early. And then they're lower likelihood for receiving your typical ACS care when they're in the hospital, including antiplatelets, beta blocker statins, ACE or ARBs. So focusing on cardiac rehab, this is a class 1 AHA recommended guideline that patients after MI go through cardiac rehab. And it's shown to improve not only physiological parameters, but also improve depression and anxiety, which is pretty common after getting an MI, especially if you never thought you were at risk. It's been shown to improve that. It's been shown to improve vitality, social functioning, and it just overall to decrease morbidity and mortality. So we talked about less women getting enrolled and less women completing it. And those risk factors, certainly the uninsured may not be able to afford cardiac rehab. If you're single, you're at higher risk for not participating in cardiac rehab. Smokers, obesity, those are risk factors. And then again, there's that family obligation again. Setting up time to go to cardiac rehab is often difficult for patients. Sedentary lifestyle, non-white patients, and just as a caveat, all of these differences in outcomes, all of these things that are higher in women are much higher for Black women and women of color. So I just want to point that out. This lecture is focusing just on women in general, but we have to keep in mind that there's even more disparity based on race. And again, that incidence of depression after MI is much more common in women. So it's harder to get that motivation to go and complete cardiac rehab. And women who have less social support are less likely to complete it. Now, one thing that has been shown to help, because these treatments, this cardiac rehab has been designed on studies for men, is that there's been studies showing that a tailored approach to women actually has better success. So we're looking at motivationally enhanced programs that are designed specifically for women, cardiac rehab in the house, again, to help avoid those familial obligations or other obligations. These tailored approaches have been much more successful, higher completion rates, greater attendance, and you have improved quality of life and less depressive symptoms. So social functioning, again, is improved, general health is improved, and especially mental health is improved. And remember that depression is associated with a higher risk of MI. So outcomes, and this again is pretty stark. Within the first year of MI, more women will die than men of a similar age. And there's also higher in-hospital mortality and major adverse cardiac events at 30 days. There's also increased complications after an MI. So heart failure, cardiogenic shock, in-hospital stroke. And just like our patient that we showed in the case conference, she did have a drop in her EF, so she did suffer from some cardiac loss of function. And women, again, tend to have more bleeding complications, and being a female is an independent risk factor for bleeding. Women tend to have longer hospitalizations. And really interestingly, women have 30% more readmissions. So a much higher morbidity, including mortality, after your first MI. So this is looking at outcomes. This is from the AHA, published in 2016. The red line is women, the blue line is men. And you can see over time that men have had a steady kind of decline in death after MI, and that's due to preventative measures, number one, goal-directed therapy. And women have had a less steadier decline. And when you look at young women, the gap is much wider compared to men of the same age. So women under 50 have a much higher risk of death and complication from MI than men under 50. This little blip at the beginning where women deaths fall under the mortality of men probably has to do with less consideration that this woman died of MI than actual true decrease in risk factors and decrease in deaths. So although women are doing better than they were, again, looking at that difference in young women, there's really a big gap there, and there's a much higher incidence of death 1 year after coronary artery disease or after ischemia, and higher risk of in-hospital mortality as well. So there's other factors influencing outcomes, and it's been shown that having a female physician for females who've had MI, and including male physicians for men who've had MI, has been shown to have better outcomes, including improved survival rates and decreased readmission. So the survival gap in women can be decreased with male physicians, and they've shown that males who have a higher caseload of female patients or a higher number of female colleagues in their practice have been shown to have improved outcomes as well. And this can be teased out by different things, but studies have shown that that men tend to have a bigger survival gap when they have female patients. And part of this could be just crucial counseling and women tending to feel that emotional connection with a female provider. And there may be and may not be, again, looking at my bias, that still exists to a degree, but there may be less bias of reassurance when dealing with women and their risk for heart disease. So what does the future hold? Well, it's not all that good. So this was published by the American Heart Association in February of this year, and it was forecasting through the year of 2050, looking at risk of classical risk factors. So a 10% rise in hypertension, 10% rise in the incidence of diabetes, and almost a 20% rise in obesity. And it'd be interesting to look with the advent of the new class of obesity medications to see how that affects some of these women and their heart disease, because not only do they have the weight loss effect in decreasing metabolic problems, but they also can be cardioprotective. So I think that is going to make a difference, and that's time will tell. Also, inadequate sleep is a risk factor for heart disease. There was some recent study that came out about shift workers and them having increased risk of death and heart disease. Stroke and coronary artery disease will also increase. And what this tells us is that these projections tell us we're not doing well enough right now. We may be improving, as you can see in that mortality graph, moving in a downward trend, but current efforts are inadequate, and there is really a need for sustained action. And also, just in terms of adults having these increases, we're also going to see increased rates of diabetes and obesity in kids. And so they're starting to look at cholesterol levels in kids now and linking that to higher risk of coronary artery disease. So even in pediatrician offices, this is something that needs to be addressed. So moving forward, what can we do? So starting in the upper right-hand triangle, we need to increase patient awareness, and that can be done at the gynecologist's office, again, at the pediatrician's office, PCP office, basically any point of contact in the medical system. We need to be talking about risk factors in women and their risk for heart disease, and the fact that it is there and that it's really the biggest cause of death in women. And then also increase clinician awareness. So a lot of this is through gender bias, and it's both in men and women. But just understanding the fact that women can have non-obstructive coronary artery disease, so at that young age, and still have multiple pathways to have an ischemic event. Prevention is the key, and I think we're all working to do this very well. Patients who are hyperlipidemic are on statins, and there's recommendations for lifestyle modifications, and whether or not a patient follows through, I think is one area that we could somehow improve on. And then there used to be that little red dress campaign. I don't know if it was from the 80s or 90s, but it was there to help increase people's awareness of heart disease. Well, that's kind of fallen to the wayside. You don't hear about that anymore. So better public health programs, and that could be through education in schools and through community organizations, and also through public campaigns. Bring back the red dress. Let's get this more into people's mindset. And we need to better manage chronic disease. And again, I'm really curious how these GLP-1 drugs and some of the newer drugs that help with diabetes and obesity, how these are going to affect outcomes. And we also need more women in clinical trials. There are very few randomized control trials that deal with women and ischemia. So we need to work harder to make that happen. So I just want you to remember and to take this away with you as you go to see your next patient. Please do not underestimate the risk of heart disease in women, especially those younger women who are more likely to have a missed MI and delayed diagnosis. Consider ACS, again, for that patient who's had multiple episodes of angina, who's had the negative workups in the ED, may have had a negative cath. Just consider ACS in these patients. And then consider those specific sex-related factors. So the psychosocial component, the metabolic component, the hormone component, and realize that these risk factors we don't typically think of, but they're there. And then also just evaluate your own bias. Again, I have bias, and I have to overcome that bias when I have that young female patient in front of me. So I'll open it up to any questions or reflections or comments. If there's anyone online.
Yeah. Great. Thanks so much, Dr. Beyer. We do have some questions, but we'll start with some thoughts here in the room.
Thanks, Dr. Beyer. I imagine you're connected to Mary Imbeden and her work at the Cardiovascular Institute.
No.
I already forwarded her this talk, and you should connect because she's doing projects to reduce door
Fantastic.
to balloon and door to EKG. My question, I know you said PCI is actually bad if we have like SCAD or we have Minoca, we can actually do harm with PCI. And you had a slide about diagnosis with like CT something that I wasn't quite sure about, or endovascular ultrasound. And I was just going to ask, like, if you could run the world and build kind of a pathway for a woman presenting to the ED with acute coronary syndrome, knowing it's often not plaque rupture, what is the right diagnostic step we should be taking beyond the EKG?
Well, just initially, the EKG is not that sensitive in women, and in the ED, we're looking at cardiac markers. Obviously, if you've got the EKG changes, there's something going on, but looking at cardiac markers to look for ischemic events. And again, these women who come in with angina often are not going to get diagnosed. But looking at somebody who goes to the cath lab, there's a great lecture that I listened to back in the fall. It was a interventional cardiologist here who is doing that endovascular ultrasound, endovascular optical coherence tomography, the CTCA, to diagnose some of these patients who've had negative caths, but who've been shown to have ischemia. So it's happening at the interventionist level. Yeah.
I think you were referring to Richard Sohn's talk. So he gave grand rounds a couple of months ago. One of the big takeaways I took from that was that, if you do have a case like this where they had a negative cath, but they still have anginal symptoms, is to still make that referral to cardiology with maybe like in the comments, say like evaluate for Minoka.
Yeah. Well, it depends. In some cases, it can, like in SCAD, in the arterial dissection, it can actually make, not into arterial dissection, I'm thinking, I think it was vasospasm can actually make increased vasospastic events. So I was like, really? I don't know the pathophys behind it, but that kind of surprised me.
So this is super timely for me because my morning to-do list, my last patient of the day was a 42-year-old who gets chest pain most mornings after she takes her kava. And she's also a chronic kratom user. Do you have any familiarity, since you're at the front lines of the risks? I was sort of quickly trying to do a search, and it's hard to figure out whether or not there's a clear association.
Well,
And I don't even, like, if I send her for a stress test, I'm assuming it's going to be normal. So I was just going to email Lori Tam.
So some of those stimulant drinks, again, stimulants can increase vasospastic events. They can potentially increase dissection. So in the ER, I also counsel people, and in the urgent care, I'm just like, you got to stop drinking those. Our staff downs them like candy to help stay awake, but there is a higher incidence, I think, specifically of vasospasm with those kind of stimulant drugs and these drinks. So, well, that's good news. That's good.
Great. Well, others ponder questions. I have one. Thanks for talking about presenting symptoms, and I just wanted to return to that a little bit. In internal medicine, of course, we think a lot about pretest probability. And so here we are talking about like do not miss cases. And also, in some patients, our pretest probability is going to be low for acute coronary syndrome. So you have so much experience, and I wonder if you would just talk to us a little bit more just particular things that you may specifically ask for in the history or aspects of how the patient may look in terms of their physical presentation. Just want to return a little bit to things that might help elevate our level of concern.
Sure. I think first of all, you have to go back to risk factors and taking in these non-traditional risk factors. Number two, you do a thorough review of systems, as I'm sure all of you do. Your internal medicine docs, you go fast, but the ER doc goes a little faster in terms of trying to get the history. So you're getting a good review of systems. Women who I've found who are in the midst of an MI typically don't look great, but this woman in the case we discussed, she didn't, aside from being emotionally labile and anxious, she at that first visit, she didn't look horrible. So it's hard to pick up on those cues. For any patient, because I work in the urgent care now, so we don't have access to troponins and things. For any patient I would have gotten a troponin on in the ER, they're going. Okay. And then maybe after seeing this and researching this, they might be going more often. But if you think of that and say, I'd really like a troponin on this patient, if I just knew, that patient should be evaluated.
Great. Speaking of troponins, we have a question here. Returning to those challenging patients with microvascular dysfunction, and who often are presenting with chest pain repeatedly, do they typically have an elevated troponin?
If it's angina, no. But if it's a true ischemic event, yes. So you can get ischemia from this microvascular dysfunction as well. So it just depends on the level of their acute coronary syndrome, whether it's anginal or whether it's an anginal equivalent, or whether it's true ischemia that would show up on labs and plus or minus an EKG.
I never have any answers, but I have lots of questions. So I can get, my bias is that I can probably be falsely reassured if pain has been going on for days and there are no EKG changes. So is that different with Minoka? Like I would expect if you'd been having constant pain for 3 days, not pain that's coming and going, that you would have a troponin bump or EKG changes.
Yeah, you can look for Q waves. You may have, queued out, as the cardiologists like to say. So there may be some subtle EKG changes. If it's a true ischemic event, you may see other signs like shortness of breath. Remember, women tend to have more complications from their MI, so more CHF is a lot higher. CHF is a lot higher after an MI than it is in men. So you look for subtle differences like shortness of breath, some of these other little things. But for the most part, you may not see these changes. And in the ED, we still will run a troponin, and may do serial troponins. But when you consider somebody who's had pain for that long, is it less likely to be an MI? Maybe. But I had a patient in the urgent care maybe 6 months ago who came in, and it was like same thing. It was like, oh, it's just after I eat that I have pain right here. Every time I eat something, I have pain. So I'm thinking, oh, she's just got GERD or whatever. But then I asked about shortness of breath, and she's like, yeah, whenever I lay flat, whenever I go to sleep, I can't go to sleep because I feel short of breath. And so that threw up a red flag for me. And her EKG looked fine, but she maybe had a little crackles on lung exam. She had no pitting edema. Her legs were a little big, but no pitting edema. But on chest x-ray, she had a huge heart. So I sent her to the ED. Her troponin was through the roof. She probably had her MI a couple days ago, but that was a near miss.
This is just a very general sort of question. Has anybody ever done any studies comparing, acute coronary syndrome in female physicians versus male physicians? And has that been related at all to specialties?
ER. No, I have not heard of any studies specifically to that component, but shift work is a risk factor, independent risk factor for coronary artery disease. And so I would say things like trauma surgeons who are on 7 nights in a row, 7 nights off, ER physicians, anesthesiologists, if you're a hospitalist and having 2 nights all the time, you're probably going to see poorer health in these categories. And ER physicians have a shorter lifespan than all of their specialties. It could be from climbing Everest, but yeah, they've been shown to have higher disease burden. Mm-hmm. Yes. Yeah. Mm-hmm. It is hard to put together. And again, a lot of these research studies in the past have not had sex-specific data reported. That's been underreported. So it's hard to glean these differences. And that's why more randomized control studies are needed. So, and I've got various references. So those will be on the slide deck.
Great. Well, thank you so much, Dr. Beyer, for really enlightening talk. I'll end with just a couple of reminders. Next week is the final grand rounds of the spring session, and then we'll return Tuesday immediately following Labor Day. And you can catch video recordings or podcasts of all of the grand rounds, including Dr. Beyer's today, Dr. Soane's previously on ANOCA and MINOCA on the Providence CME website. So thank you, everybody.